Hi, I'm Rupa Basu, and today I'm going to talk about the health impacts from extreme heat. I'm currently the chief of the Air and Climate Epidemiology section at the Office of Environmental Health Hazard Assessment, which is part of the California Environmental Protection Agency. First, I'm going to start with some international and national headlines. Heat and heat waves in particular and health impacts often make the headlines. But if you look at the numbers here, it looks like there's about 107 deaths in Oregon, maybe 2,300 in India in another heat wave, 760 in another one. Well, there's heat waves all throughout the world, but a common problem that they all have is that they're grossly underreported. Next, I'm going to talk about some of the reasons why heat-related deaths are so underreported and give an example of a couple of epidemiologic studies where we've tried to address this issue. So first, in the US, there is no systematic definition for heat wave or heat-related deaths and illnesses. So it affects both the exposure and the outcome. So heat-related deaths or illnesses are often only reported when a heat wave occurs or when no other cause of death is suspected, resulting in a surveillance bias. In this first study, I am talking about the 2006 heat wave, where we conducted an epidemiologic study to look at all excess total deaths that occurred during this 2-week period. And we found that the number of deaths were actually 3 to 4 times greater than what was reported in the coroner's report, which was about 140 deaths following that heat wave. In the second study, I collaborated with the Scripps Institute of Oceanography to look at regional heat waves, which is very important. Often we miss a lot of heat waves just because the exposure is the area is too large or the population at risk isn't clearly defined. So in this study, we found that there was actually only 6 of 19 regional heat waves from 1999 to 2009 had a national heat advisory issued by the Weather Service. In California, in 2018, we published the 4th assessment for the climate change, and it kind of mirrored the study that was done by the US EPA at the same time. But it's important to realize that just like regional heat waves are important, also California and all its microclimates are very important to consider. If you look at all the different ways that were impacted by climate change, temperature, sea level rise, snowpack, drought is a big one. I really focus most of our studies on temperature or heat. And as you can see, it's a very high risk for now and also in the future. So the prediction is that between 2 to about 9 degrees Fahrenheit increase will occur in the next century if things continue the way that we're going. And of course, that's not acceptable. And the amount of health impacts that would be associated with this increase would be astronomical. So I'd like to just go over some of the studies that we've conducted so far at our office, really focused on some mortality studies, some morbidity, hospital visits, emergency room visits, mental health, some infectious disease, adverse birth outcomes, which is turning into a bigger field. But really, we're trying to capture all different types of health impacts that affect different populations. And what we've found is that heat really affects nearly all organs in the body. So, of course, there's the classic heat-related illness and dehydration that we often see during heat waves or even during higher ambient heat exposure. Cardiovascular mortality and morbidity are huge outcomes, specifically heart attacks or congestive heart failure. And mental health is an area that we've recently explored and is really starting to pick up a lot of studies how heat and just temperature in general affects mental health, suicides, homicides, as well as some specific categories of mental health outcomes. Adverse birth outcomes, which I will talk about a little bit more, include preterm delivery, stillbirth, low birth weight. We've seen some connections with liver and kidney disease, gastrointestinal diseases, respiratory diseases, which we have to be careful because sometimes these are confounded by air pollutants, as well as links with diabetes. So next I'm going to summarize some of our earlier studies on temperature and mortality. What we found is that every 10-degree Fahrenheit increase in same-day mean apparent temperature, which is a combination of temperature and relative humidity, was associated with about a 2.3% increase in mortality among the general population. It's very important to study vulnerable subgroups, such as the ones that I've listed here. For cardiovascular mortality, for example, we found a greater increase, and this really drove most of this overall mortality that we saw in this study, with a 2.6% increase. Among African Americans, the rate was almost about 5%. And then we also looked at some subgroups by age. For example, among infants under 1 year, found about a 4.4% increase, but among deaths in African American infants, the increase was about 13%. Major findings from our temperature and morbidity studies is that there's various outcomes that are linked with hospitalizations, such as increased dehydration, increased acute renal failure, ischemic stroke, pneumonia, all respiratory diseases, and diabetes. For emergency room visits, we found that temperature was associated with heat illness, greater dehydration, also acute renal failure, intestinal infections, hypotension, all mental disorders that we looked at, as well as ischemic heart disease, ischemic stroke, cardiac dysrhythmia, and diabetes. I'm going to focus a little bit on the mechanism for these last outcomes that I just discussed. So heat is associated with ischemic outcomes, not hemorrhagic, and that's because ischemic outcomes are associated with increased cholesterol, whereas hemorrhagic outcomes are associated with increased blood pressure. During heat exposure increases, we know that cholesterol levels are increased, but actually blood pressure decreases. So it makes sense that there were positive associations with ischemic heart disease and stroke, but negative associations with hypertension or high blood pressure, aneurysms, and hemorrhagic stroke. Populations at risk for heat-related deaths and illnesses include elderly, pregnant women, infants and young children, outdoor workers, those living alone in higher apartment or condominiums buildings, socially isolated populations, and young athletes. Also, we've recently looked into the literature of temperature and mental health and found that there are certain medications, such as antidepressants, that actually affect that increase heat-related deaths and illnesses, as well as beta blockers that are used for heart disease. Also, a huge effect modifier of this association is poverty, and there's different ways that poverty is measured. It could be socioeconomic status. Sometimes we use race or ethnic group. Then if we have, income levels or other markers for socioeconomic status or poverty, we often use those. So I'm going to talk about a previous study that we conducted on temperature and risk of preterm delivery. We looked at preterm deliveries between 20 to 36 weeks. limited them to singleton births and at least 20 births per county, and then ended up with a study population of about 60,000 births and considered the weekly lag, or lag 06. We found that um, we started out with the county level estimates and then combined all the county level estimates in these 16 counties in our study to come up with an overall regional estimate and a meta-analysis. I wanted to show the county level estimates just to kind of point out how varied they are. Sometimes in the smaller counties, we even see some negative estimates and then some really positive estimates as well. So that's why it's important to get an overall estimate as we did in our meta-analyses to really kind of tease apart these differences or heterogeneity in. So next I'm going to go over some of the results from this study. Here is the percent change from preterm delivery per 10-degree Fahrenheit increase by maternal race or ethnicity. Overall, we found that the result was about an 8.6% increase per 10-degree Fahrenheit increase in apparent temperature. And you can see here that we have Black, Hispanic, white, and Asian mothers, and that there's a disparity by race. Clearly, Black mothers have the highest risk with almost 15%, which is almost double the overall result. Hispanic also had elevated risk compared to whites, and so did our Asian population that we were able to create with our own data set. By maternal age, you could also see that there's increased risk for younger mothers, and there's what we call a dose-response relationship here. So the older a mother is, the less risk in our study population for temperature and preterm delivery. We expanded our study by collaborating with the Kaiser Division of Research. And we were able to look at other maternal factors, such as behavioral factors and medical conditions. What we found is that factors such as smoking, alcohol use, as well as medical conditions such as pre-existing diabetes, pre-existing hypertension, as well as gestational diabetes and hypertension, all had increased risk for preterm delivery from temperature, and actually pretty pronounced risks of anywhere from 32% to about almost 86% here. And we also saw a relationship with preeclampsia. So it's really important to look at, again, vulnerable subgroups and high-risk groups. The studies that I just presented were some of the earlier studies on temperature and preterm delivery. Since then, there's been a lot of evidence in other areas throughout the US that have conducted similar studies. And so a couple years ago, I published a review paper with some co-authors outside of my organization on air pollution, heat exposure, preterm birth, low birth weight, and stillbirth in the US. It was a systematic review, and there were 68 studies, including over 32 million births in the US between 2007 and 2019. What we found is that all of these exposures had a pretty substantial risk for these adverse birth outcomes, and also that there was a consistent disparity by race and ethnicity. Next, I'm going to talk about some of the mechanisms that we should look for when looking at temperature and adverse birth outcomes. It often starts with dehydration, acute dehydration, which is not often connected to the heat exposure, the ambient heat exposure. And so just a simple headache or nausea, vomiting, all of these types of things are symptoms of dehydration and should be carefully looked for in pregnant women. This can lead to oxidative stress and inflammation, which releases oxytocin in the body and then decreases uterine blood flow. And what happens with this mechanism is that there could be decreased fetal growth and which induces labor, often prematurely. It's important to realize that vulnerable populations may be different by health outcome. What I really talked about here is only vulnerable populations from preterm delivery, so Blacks, Asian, Hispanic mothers, younger age, hypertension, diabetes, alcohol use, and smoking. But I wanted to point out that if you look at another study, such as a study of mental health that we did, the populations at risk could be quite different. Some overlap. There could be differences. Hispanics, children living in non-coastal areas. We saw some gender differences here, warm and cold season, so it's not as seasonal as we saw for preterm delivery. And it's a very acute effect. And that means that from a public health response point of view, we have very limited time to make some changes to prevent these associated health outcomes. So the last slide I'd like to leave you with is that climate change has many different mechanisms. It's multifactorial. For example, heat could relate to drought, which could relate to wildfires, which eventually leads to migration and displacement. Thank you so much for your attention. And if you have any questions, please feel free to contact me at the email address listed here. Thanks.